Yeah, I'm very happy to invite all these participants to this 13th Zoom webinar. So today we have a very interesting topic on spinal tuberculosis. Actually, spinal tuberculosis is always a controversy in India. Despite of being such a common disease, we have a lot of questions that are still yet not yet answered. Right from whether to do a biopsy, if you are doing a biopsy, what test to be done, if it comes as TB, what how to be managed in the form of conservative or surgical. If you're going for surgery, whether to go anterior, posterior, and how long to give TB treatment is always a controversy. And today we have Dr. Vibhu, who is a spine surgeon from Ganga Hospital. He's a very good senior of mine, even, and I know him from many years. He's a good academician, and he finished his FNB training from Ganga. And in addition to that, he went for US and as well as Canada to have advanced training in scoliosis and other fellowships. So who else can answer these queries to us? It's none other than Dr. Vibhu. I welcome Dr. Vibhu to share his experience about TB spondylodiscitis with us. Over to you, sir.
Thanks, Ram. Good evening, everybody. Hope I'm audible. Tonight, the topic is tubercular spondylodiscitis. I'm pretty sure it's one of the most familiar topics for most of the attendees today. We have been having cases since our residencies that we would have presented. And the idea of today's topic is to make things learn a few things about the principles of management, and it has been pretty useful week for me preparing for this talk, and I'm pretty sure I hope that everybody goes ahead with a little more points and wisdom. I would first of all like to thank the person who is behind this series of webinars, who has been making all this possible. He's none other than our friend COVID-19. He has been gobbling up all the tissue papers and hand sanitizers over the past weeks. And big surgeons, all of you guys who would have been wanting to be busy in wards, have been brought to their restrooms, living rooms, bedrooms, and sit with laptops. And of course, Rams, who has been taking so much of pain organizing these seminars over the past weeks. Now I'll go on to the topic. Little brief introduction. Spondylodiscitis is basically the infection of the vertebral body, the disc space intervening, and the epidural space, and then the paraspinal region. So it constitutes about 2 to 7% of musculoskeletal infections. Etiologically, it is broadly classified as pyogenic, granulomatous, of which the most common is tubercular, which is today's topic. It can be parasitic. Tuberculosis is it comes under a chronic granulomatous spondylodiscitis category, which typically the infections of this category, they present with the typical feature of a pathological feature of granuloma, which involves necrosis, typically caseating necrosis in tuberculosis, with collection of chronic inflammatory cells, the macrophages, lymphocytes, and of course the Langerhans giant cells. So this category of chronic granulomatous infections, they have an insidious onset and gradual progression. It is an ancient disease, right from the days of Charaka Shushruta. The Egyptian literature, Peruvian literature, they all have mentioned this disease. And in modern medicine, Sir Percival Potts is credited with the most contribution to this disease. It's in the infection of the vertebrae and paraplegia consequent to it. A little bit about epidemiology. It's a huge burden. We all know it. 10% of patients with active pulmonary disease also have a concomitant skeletal tuberculosis. So, and 50% of skeletal tuberculosis is actually tuberculosis of the spine. That's how much the burden is. And it is disease is a disadvantage. So the developing nations, third world, so-called third world nations, they bear the biggest brunt of this disease. However, there has been a recent resurgence in even the developed world moving to immunodeficient conditions, elderly patients, and there is a significant global migration from the developing world to the developed nations. And of course, of prime importance these days, it is an utmost important responsibility of each one of us. Is the category of the drug-resistant tuberculosis. It's been constantly on the rise, and it's careful management and regular follow-up of these patients can help with this particular category of tuberculosis. Etiologically, the Mycobacterium tuberculosis complex, of which Mycobacterium tuberculosis species is the most common bacillus. It's an aerobic bacillus. It's a slow-growing bacillus with lipid and peptidoglycan-rich cell wall. And the characteristic feature of this tuberculous bacillus is that it remains dormant over a long time. It's during the unfavorable conditions, and when the favorable condition, it has a capacity to get back active. And therefore it actually stays in different stages. So that makes the drug therapy more complicated. Pathogenesis, the most common spread of this bacillus to the vertebra is from some primary site. It's a hematogenous spread on most occasions, and most commonly it's from the lungs. And this hematogenous spread is through the conduits, like arterial transmission or venous transmission, or rarely sometimes the lymphatic transmission. Most common is arterial. And pathologically, the disease is classified based on the involvement of the part of the vertebra. We are all well aware of it. I'll just go over it briefly. Where the most common type of disease in the vertebra is paradiscal involvement, by which the metaphyseal region just under the end plate, that is the most vascular part of the vertebral body, and therefore the disease, the bacilli gets transmitted to that region, and the paradiscal portion of the vertebral body, that's the most commonly involved initially, and most of the disease is paradiscal. And secondary to the paradiscal vertebral body involvement, it involves the disc, and thus the disease progresses. However, the other types of disease, especially in children, it can be a central disease, involves the centrum of the vertebral body. It's more because the body in the children, it's cartilaginous. It can be just involving the posterior appendage, which is not very common. Posterior, just under abscess under the anterior longitudinal ligament, which is called the anterior disease. And it can be panvertebral, or it can be even non-osseous. More common in sacroiliac region, where it's just an abscess without much vertebral body involved. Histologically, these lesions are characterized by what we call as tubercles. Tubercles are the granulomas that we talked about. So I am, as like most of the orthopedicians, the top picture on the right, it's not much. I don't decipher much from that. The bottom picture seems more understandable to me. But whenever I see a report from the pathologist saying there is a caseation necrosis or Langhans giant cells, it confirms me that it's a tubercular lesion. However, these lesions, a lot of times, the histopathological report also comes up as chronic infective or chronic non-specific spondylodiscitis. That's a more common report, as most of us would have been aware, that we come across. And these tubercles, basically, they are the basis of pathogenesis, and they coalesce together and they form what we typically see as the cold abscess. The cold abscess is, in fact, it's the cavity of the cold abscess is filled with caseous material. The cold abscesses, they are devoid of any local inflammatory signs as compared to the abscesses in pyogenic infections. So going on to the pathogenesis of how the vertebral body destruction and deformity starts. So there is a chronic infection which leads on to an inflammation. So this chronic inflammation, it leads to increased vascularity, especially around the paradiscal region, and that leads on to bone resorption, and consequently there is a vertebral body collapse, and that leads on to pathological fractures, and over time the kyphosis. Apart from the bony involvement, there is also this extensive abscess formation, which is characteristic of this disease. And this abscess, it spreads gradually into the epidural space, into the prevertebral region and the paravertebral regions. The patterns of bone destruction have been classified as one fragmentary, or it can be osteolytic, or it can be subperiosteal. The B and C, unfortunately, are rearranged. And the last one is localized. And there is an important thing that we need to understand in the pathogenesis of deformity progression in adults against children. Both in adults and children, there is a good amount of vertebral destruction which happens during the active phase of the disease, and that contributes to deformity. However, in adults, after the disease is healed, it doesn't progress unless the curve is greater than 60 degrees. Curves greater than 60 degrees have been shown to display some propensity to progress. However, in children, especially in younger children, less than 7 years, the remaining growth actually makes the curve progression, even during the healed phase, quite unpredictable. This was described by Dr. Rajshekharan as 3 different curves of or patterns of progression of the deformity. So he had seen that it's not always the same, and based on the observation, he had classified the curve progression during the healed phase into 3 categories. We all are aware of it. Type 1 curve progression is where the curve continues to progress even during the healed phase. Type 2 curve progression, it actually improves, and that's in 40% of the kids. So it's not always that the kids start having a worsening of deformity during the healed phase. And in 20% of the kids, it actually remains constant. That is the type 3 curve progression. So for us, the first type, the curve type 1, is of most importance. That is, we need to identify which kids are at a risk of progression of the curve further on. So Dr. Rajshekharan had put forth the spinal risk signs, again, quite well known. And the basis of this spinal risk signs is that we all know that in tuberculosis, there is involvement of the anterior column and the middle column. But when there is an additional disruption, either anatomically or functionally, there is a disruption of the posterior column. That's when there is a very high chance that the curve follows a type 1 curve pattern. And basically, passage joint subluxation, retropulsion of the vertebral body, toppling of the superior vertebra, so is that the anterior margin of the superior vertebra is actually in contact with the caudal vertebra, or lateral translation. So all of these just mean that there is a additional posterior column disruption if we look at it carefully. And whenever there is 2 or more of these signs, they had shown that there was a high degree of progression of the curvature. So this is the curve pattern. In the adults, it obviously most of the times it stabilizes after the healed disease unless it has already reached the threshold point of 60 degrees. Whereas in children, it follows one of the 3 patterns.
Sir, sorry to interrupt. Can you keep your mic close to yours?
Am I audible now?
Yeah. A lot better. Please go ahead.
Thank you. So these are the spinal risk signs: the facet subluxation, posterior vertebral body retropulsion. This is the toppling, where the anteroinferior margin comes in contact with the caudal vertebra, and this is on the coronal plane, the lateral subluxation of the vertebra. Going to clinical presentation, as previously mentioned, there is always an insidious onset and gradual progression of disease. Constitutional symptoms are not very common. Less than 40% of these patients present with some constitutional symptom. And the most common constitutional symptom, as we all see, is we typically describe as evening rise of temperature in tuberculosis, and loss of weight, loss of appetite. Usually, because it's such an insidious and gradual progression, um, there's a usual delay of around 3 to 6 months between the onset of symptoms to the diagnosis, and therefore a high index of suspicion is very essential, especially in endemic regions like ours, in immunosuppressed or socioeconomically deprived people. The four most important clinical features that TB presents with. First is the most common symptom is pain. So almost 90 to 100% of patients present with either axial or radicular pain in the back. Can be a continuous kind of pain, which is typical of inflammation or a direct mechanical pressure from the abscess. Or it can be a mechanical or an instability kind of pain, which is secondary to the destruction that the vertebral body has undergone, as previously discussed, or the discal disruption, leading on to deformity or instability, or the characteristic pain which has been described for tuberculosis, the night pains or the night cries, secondary to venous engorgement in the inflamed spinal tissues when we lie supine, or due to the relief of spasm during sleep. The second most important clinical feature is a cold abscess, which is seen in around 70% of the patients. As previously mentioned, these abscesses do not show any local sign of inflammation, unlike the pyogenic abscesses. These have a huge propensity. These are chronic abscesses, so they collect over time, and they have a huge propensity to track along natural planes, subligamatously, and they present in a variety of locations. The lower thoracic cold abscesses, around 40 to 50% are in the lower thoracic region, and lumbar region is around 35 to 40%. The abscesses in the cervical region, they can track into the retropharyngeal spaces or other neck spaces, or they can even track along the brachial plexus and present in the axilla or the medial part of the arm. The thoracic abscesses, they can track along the intercostal neurovascular bundle. They can go present along anywhere along the chest wall, or they can present anteriorly in the mediastinum. Or sometimes the thoracic abscesses actually can pass across one of the orifices in the diaphragm, and they can reach the abdomen. The thoracolumbar or the lumbar abscesses, they tend to track along the psoas muscle, and they may present in the inguinal region, the thigh, the popliteal region, or the calf. Or they can present as luteal or lumbar abscesses. They can even present in the retroperitoneum. So when these abscesses are not treated, they tend to present as chronic draining sinuses. The third most important clinical feature is presentation of the spinal deformity. Spinal deformity is a critical component of the disease, as we had discussed previously in the pathogenesis. The three common types, we all have heard of it, when based on the levels of vertebral involvement. It can be a knuckle involvement, knuckle pattern, or a gibbous pattern, and 2 or 3 vertebral bodies are involved, and when it's global kyphosis deformity. The fourth most important clinical feature, which is of all the previous ones, it's the most serious complication. It's a neurological deficit. You say in developed nations, it's around 10 to 20% incidence among the patients, and in developing countries, it's twice as common. And neurological deficit may present as radicular symptoms, or a focal motor weakness, or as sensory deficiencies, or with autonomic disturbances. Classically, neurological deficit has been classified. These two classifications everybody would have heard of. Sutton's classification as early onset, late onset deficits. Hodgson's classification is of prognostic value. They classified as neurological deficits occurring during the active phase of the disease versus neurological deficits during the healed phase of the disease. Overall, whenever there is a neurological deficit which happens during the active phase, it carries a better prognosis. The common causes for a patient to develop a neurological deficit during the active phase of the disease include, the most common possibly is mechanical compression, maybe due to an epidural abscess or a granulation tissue, or the destruction causing a pathological fracture, spinal instability, or pressure from direct bony fragments. Apart from this, there can be a direct involvement of the spinal cord, which can cause deficits, or rarely it can directly involve the arteries can get thrombosed, and that can lead on to spinal cord ischemia. The deficits during the heal phase, they typically carry a poorer prognosis. They are broadly classified as deficits due to static causes, which include cord atrophy or neural fibrosis during the healing phase, or myelomalacia due to chronic stretching. So there is both a traction injury or compression injury and a compression injury happening due to chronic severe deformities in heel tuberculosis. So this is it can be the cord can be chronically stretched over the internal gibbous, or there can be a direct compression from the internal gibbous per se. And it can also be due to dynamic causes. There can be a pseudoarthrosis. It may not have fully healed with the bony fusion, and there can be in very severe kyphotic deformities, especially in buckling collapse. There's instability. If it is fused at the apex, then the instability can be at the proximal or the distal levels due to the biomechanical disadvantage of the vertebral column as such. We all have heard of the Kumar's classification. It has traditionally been the way to classify neurological deficits from spinal cord involvement in tuberculosis. So broadly, we classify as whenever there is an involvement of spinal cord. So you can classify as stage 1, where the neural deficit is only evident on the clinician's examination, either with gait instability or the other upper motor neuron signs. Stage 2 is when there is a motor deficit, but the objective muscle power is at least 3/5. Stage 3 is when there is a severe motor deficit. It's called paraplegia and extension, with severe spasticity, and the sensory deficit is less than 50%, and there is no bladder or bowel deficit. And stage 4 is complete motor deficit with significant sensory deficit of greater than 50%, significant flaccidity. It's called paraplegia and flexion because there is significant flexor spasms and contractures by this time, and there is autonomic involvement also. However, we tend to use Asia grading of late for any spinal cord injury, including spinal cord injury secondary to tuberculosis, and possibly this is becoming less relevant. Still, it's a very interesting classification. Apart from these typical presentations, tuberculosis of the spine can present with other atypical presentations too. Been mentioned in around 2.1% of patients. Of these, I would like to say that intraspinal granulomas or spinal tumor syndrome, without much bony involvement, there is a granulation tissue in the epidemiological region which is causing the symptoms, deficits. Or more commonly that we should all be aware of is it can present with non-contiguous multi-level involvement. So as we can see in this picture, there's if we just get localized imaging of the thoracolumbar region, we may completely miss the severe disease in the cervicothoracic region. And this we should keep in mind. And we do think that whole spine screening of the MRI is mandated to be obtained in all the patients with tuberculosis. The diagnosis, the investigations, we call it the three-pronged approach: laboratory investigations, the imaging studies, and tissue sampling. All three are important in their own place. With regard to the laboratory investigations, broadly, the blood investigations, this is almost obtained by all of us. So of these, the most important, there is an elevated total leukocyte count, which is seen in up to 50% of these patients. And the inflammatory markers, erythrocyte sedimentation rate, and C-reactive protein. The literature says around 2/3 of these patients, they have elevated inflammatory markers. At our institution, we tend to be more relying on erythrocyte sedimentation rate rather than C-reactive protein. This C-reactive protein is more, we think it's more relevant in acute pyogenic infections, but I think most of the centers do both, give importance to both. Both these investigations, they have a greater prognostic utility rather than just diagnosis. It has been quite evident that any patient with a persistently elevated ESR and CRP beyond 3 months of chemotherapy, you should consider some. It should raise a bell in our minds regarding an alternate diagnosis or a drug-resistant tuberculosis, or whether the patient is compliant, or whether the dosing is adequate for the patient's weight. All these are important. Of course, all these patients need to have a baseline liver function test, because most of the anti-tubercular medications are heterotoxic. Usually, in terms of the blood investigations, this is of utmost importance in tuberculosis. Apart from this, the immunological tests, which rely on the type 4 hypersensitivity reaction to the tubercular antigens. A MANTO test, all of us are aware, is a skin testing to the tuberculin antigen. The quantiferon assay or the interferon assay is again an ELISA-based test to identify the interferon gamma against tuberculosis, and a direct ELISA test to diagnose the IgM and IgG antibodies against tubercular antigens. So these immunological tests, however, in endemic regions, their value is very much questioned, and we usually do not get these investigations. In terms of laboratory investigations, we tend to rely on the other blood investigations which I mentioned. Imaging studies, obviously of utmost importance. Plain radiographs, everybody should get a plain radiograph in these patients. But usually in the initial 3 to 4 weeks, there is not much that is seen. But after 3 to 4 weeks, the intervertebral space narrowing, the decrease in the bone density, lytic lesions, collapse, kyphosis, they are all evident. But we should also be looking out for the soft tissue shadows for the chronic abscesses. So in the cervical spine, retropharyngeal abscesses, the common terminology is the bird nest appearance and fusiform appearance in mediastinal abscesses, and aneurysmal sign or scalloping of the anterior surface vertebrae in typically the anterior disease. And obviously, all these patients, you should have a plain chest X-ray also to check the pulmonary status. And CT scan, we typically get CT scan in all our patients who undergo or plan for surgery, because it shows in a much better way the bony anatomy whenever we're planning for surgery. So we always get in our patients who are planned for surgery, and it's especially useful in the craniovertebral junction or the sacral regions. The soft tissue calcifications, though, can be seen on chest plain X-rays also. They are much better seen here in the abscesses that can help with the diagnosis. And very small lesions in the bone, they can be better seen obviously with the CT than plain radiographs. The nuclear scans have been described in the literature. Technician 99mm bone scan and FDG PET, they have been well described. In fact, there are a good number of articles on FDG PET being used as a targeted tissue sampling modality. We can look at the high intensity inflammatory region, and we can get a biopsy that has been shown to have a better yield. And can also be helpful apart from the blood investigations, X-rays and all. FDG PET has been used as a modality to monitor the response to treatment in patients. We, however, do not use the nuclear scans in our patients at our institution. MRI is the gold standard everywhere. Very high sensitivity, very high specificity. It helps us to, it's obviously mandatory in all patients. It can help us evaluate the status of the spinal cord in patients with neurodeficit. Or we can know what is compressing granulation tissue or is an abscess. And the most important thing is it helps us in differentiating pyogenic spondylodiscitis or other tumors, especially metastasis from tubercular spondylodiscitis. As I previously mentioned, non-contiguous or stiff lesions, they can be seen in around 15 to 20% of these patients. And therefore, screening of the whole spine of the MRI can be very helpful. And whenever we suspect infection or tumors, we need to get contrast enhanced MRI sequences also in these patients. So based on the literature, differentiate between a tubercular spondylodiscitis and the pyogenic spondylodiscitis, just based on the MRI, it can be almost 90% specific. So it's that high specificity for tubercular spondylodiscitis. The characteristic features of the abscess in tubercular spondylodiscitis is there's a very large abscess and these abscesses are typically thin-walled and they are smooth-walled as compared to the abscesses in the pyogenic spondylodiscitis. And in the tubercular spondylodiscitis, there is a relative preservation of the disc or a pretty late involvement of the disc as compared to a pyogenic spondylodiscitis, where a hyperintense disc is seen quite early. And in tubercular spondylodiscitis, when the contrast is quite homogeneous. It's much more homogeneous than heterogeneous contrast uptake in pyogenic spondylodiscitis. And in Tamil, tubercular spondylodiscitis is used to be called the Tamil word for this disease was Elumburiki noi, which means a disease that melts away the bone. And typically it does that. It involves multiple vertebrae and it tends to destroy multiple vertebrae. Multiple vertebral involvement is much more common in tuberculosis than in pyogenic spondylodiscitis. And these abscesses are chronic abscesses. They are very large and they gradually track along the subligamentous areas. And one of the things that they always mention, radiologists, is whenever you see an abscess which is extending subligamentously beyond the extent of the involved bony vertebrae, it tends to be more tuberculous than pyogenic spondylodiscitis. So some good pictures. This is a lumbosacral pyogenic spondylodiscitis. We see on the stir image there is a very high intensity region in the disc, and this is quite typical of pyogenic spondylodiscitis. And this is again a stir image of the thoracolumbar region. This is again pyogenic spondylodiscitis, hyperintense disc, and we can see that the abscess is not very huge, and some paradiscal involvement, but the rest of the bone is quite normal. This again is typical in pyogenic spondylodiscitis. This is another pyogenic spondylodiscitis imaging. Here again, we don't see like a huge abscess. The abscess is quite small, and with the involvement of again, there's hyperintensity around the of the disc. These are imaging, typical imaging in tubercular spondylodiscitis. As we see, a large involvement of the sacral bone, but the disc is quite well maintained at the L5S1 region. And this is another advanced tubercular. The next one is an advanced tubercular lesion. So here again, we find that despite the degree of vertebral body involvement, we find that the disc space is quite fairly maintained, and but the bone destruction is really huge. And the next pictures, we can see how the abscesses are. These are like huge abscesses. You can see on the axial section also very big abscesses, and they tend to track subligamatously and extend beyond the vertebral body involvement. So the abscesses are much larger in the tubercular spondylodiscitis. Again, tubercular MRI has a good value in differentiating metastatic lesions from tubercular spondylodiscitis. In metastasis, the vertebral body destruction, there is vertebral body destruction, and the typical pathognomonic feature that we all discuss is a bulging posterior vertebral wall. It's characteristic in metastatic lesions. And there are soft tissue mass lesions, and there is obviously sparing of the disc. It's not going to involve the disc in metastasis. Whereas in tuberculosis, there is vertebral body destruction, and intervertebral space gradually tends to get involved as the disease progresses, and you have paraspinal abscesses, not mass lesions. So studies have shown that dynamic contrast enhanced MRI can actually show the vascularity of the lesions, and it has been shown to be of values in differentiating metastatic lesions from tuberculosis. We don't routinely get this investigations in our patients. This is an imaging in a metastatic lesion. You can typically see only the vertebral body involvement that the space maintained, and there is a posterior characteristic bulging of the vertebral body. Diagnosis, the third prong is tissue sampling. Um, at this point, tissue sampling is mandatory in all the patients before starting empirical antibiotic therapy or anti-tubercular therapy in tuberculosis. There is a high increase in drug-resistant tuberculosis that's coming up, and tissue sampling is a definite need before the inception of anti-tubercular therapy in these patients. Tissue sampling, it's a gold standard a diagnostic modality for confirmation. A tissue can be procured either under an image intensifier in OR. We do this in our institution mostly, or under CT guidance. The advantage of doing it in OR is the patient is in general anesthesia. You can insert a big Jamshidi needle and get a good chunk of core for the tissues. And all the tissues, they need to be sent, one for molecular diagnosis, which is the TB PCR, two for bacterial culture. It should not just be a tubercular culture. We should also get a pyogenic culture, both aerobic and anaerobic in all these patients, and histopathological examination. So all the sample should go for all these three testing. Tubercular PCR, it's a highly sensitive and highly specific test for diagnosing tuberculosis. The gene experts, it's a PCR based molecular study, and within as little as 90 minutes we can do a rapid detection of the DNA sequences of tubercular bacilli. And TB is a possibacillary disease too, and this can detect as little as 50 to 100 bacilli. It's highly accurate, good sensitivity and specificity, and the bigger advantage of this is we quickly tend to know the genetic mutations also which are associated with rifampicin resistance in these patients. So we can know early on during our treatment itself whether it is possibly a drug-resistant tuberculosis or not. The gold standard confirmatory test is obviously the bacterial culture. As I said, we send for all the pyogenic culture also, but for tuberculosis right now, everybody uses a Bactec, which is a liquid-based media for culturing. And all culture positive tests, they should be tested for sensitivity for both first and second line drugs. And the third part of tissue sampling evaluation is histopathological examination. This is very helpful. So all the tissues should be sent for tissue culture also. So as we discussed, tuberculosis is possibacillary. A lot of times you may not get the culture positive, and histopathology has been shown to yield, give much higher yield as compared to the culture techniques. Histopathologically, we see granulomatous lesion, as we previously discussed, and when I see Langerhans giant cells and case shading necrosis, as previously said, that's very typical. Start the patient on anti-tubercular treatment. A lot of times, it comes as chronic non-specific osteomyelitis or spondylodiscitis, and in those cases, again, we do need to start anti-tubercular treatment. And but the patient would be obviously you should be quite sincere in following up the patient that it may be an alternative diagnosis. And these, as you see, histopathological examination in the literature actually has a very high sensitivity, specificity, and accuracy in diagnosis. Treatment. So the most important thing we should all know is uncomplicated tuberculosis is primarily a medical disease. And so medical treatment, there should be no compromise. The patient, despite of whatever surgery we do, should be very careful in following up all our patients, making sure that they have the best, the required drug, which they are sensitive to at required dosages. Tubercular bacillus is a fastidious, and it's a slow-growing organism, and it typically tends to, as I previously discussed, tends to exist in different forms. It can be intracellular, extracellular, it can be dormant, rapidly growing. Therefore, multi-drug therapy has always been the norm to attack this bacillus. The goals of medical treatment are, one, obviously to cure the disease, but also to control the development of drug resistance, avoiding any complications of the drugs, which you should be careful and following the patient. The most common complications are obviously the hepatotoxicity that we should be aware of, and prevention of relapse of disease. The first and the second line chemotherapeutic agents have been described. There's a classification, the WHO. The first line treatment are the 5 drugs which we are all aware of. They're the most effective um, treatment agents. Among them, as I discussed, isoniazid. All of them are hepatotoxic, especially isoniazid. There is also, whenever we prescribe these anti-tubercular medications, we also need to supplement benzoyl thyroxine, because there is a chance of deficiency developing in these patients due to chronic isoniazid therapy. Pyrazinamide can cause hyperuricemia. Ethambutol can cause optic neuritis, and it should be avoided. It should not be given as a part of treatment in all kids, because they may not be telling about deficiencies in the vision. And streptomycin can be renal toxic, nephrotoxic. So we should be aware of these are the common side effects, and we should be aware of them. The older treatment protocols used to extend up to 18 months duration. However, MRC trials have confirmed pretty comparable results even with shorter course of chemotherapy. And the recent WHO guidelines actually say the duration quite clearly. There are 2 phases of treatment. There is an initial intensive phase and then the continuation phase. The initial intensive phase should be for 2 months duration and should consist of 4 drug regimen. And it is the principle of this initial intensive phase is to target all the rapidly dividing bacteria. And there is a continuation phase which consists of 2 drug regimen for 7 to 9 months. And these are for the dormant and intracellular bacteria to prevent any relapses. So how do you assess when the patient is started on therapy? How do you assess the patient for duration and response to chemotherapy? The foremost is clinical improvement. Is the patient feeling well? Improvement in weight, improvement in appetite. We check the weight in all these patients during every follow-up. The next is all the laboratory parameters, the WBC count, ESR, with or without CRP, and of course we get liver function tests in all these patients. I'll talk about a little bit. The X-rays showing radiological signs of healing, which include resolution of the lytic lesions, sclerosis of the bone, and reossification of the bone. MRI is also required in these patients, and they should be performed towards the end of chemotherapy. In MRI showing resolution of the marrow edema, replacement of the marrow cavity by fat, or complete resolution of abscesses is quite characteristic of disease cure. And PET CT has been described. We don't use it regularly. So we should be aware of these terminologies. What is drug-resistant pathogen? What is it? Multi-drug resistant tuberculosis is when the bacillus is resistant to both rifampicin and isoniazid. And extensively drug-resistant tuberculosis is resistant to fluoroquinolones and at least one other injectable second-line agent. So these are all prevalent. So we should be very careful whenever we should take utmost responsibility whenever we prescribe anti-tubercular treatment for these patients. And any patient with suspicion of drug resistance, we should immediately involve an infectious disease expert directly. And if the patient did not have a definitive tissue diagnosis, like I said, if it's a chronic, inflammatory, non-specific, if such reports were there, and, or the patient never had a tissue diagnosis in first place, this patient at this point should definitely have a repeat tissue sample. And overall, ambulant, long-term medical therapy with or without the use of brace is practice for medical treatment of tuberculosis everywhere. Our protocol for follow-up in patients on anti-tubercular treatment, I'll go briefly about it. 10 days after the starting of the drugs, we see the patient. This is primarily for evaluation of any toxicity. We get the blood work, especially it's a 10 days to 2 weeks. This is the time when the toxicity, hepatotoxicity especially, can be seen. So we look for the liver function test. Whenever we follow the liver function test, we tend to look mostly for the enzymes. There is the SGOT and the SGPT more than the other things. We get all the entire liver function test pre-operatively or before the treatment as a baseline. However, for follow-up, these tend to be much more effective, SGOT and SGPT. This is the initial follow-up. After that, at 4 to 6 weeks, we see the patient again. And at this point, clinically evaluate the patient. The patient usually has a good improvement in symptoms and weight, measure the weight, ESR, CRP, SGOT, SGPT, and X-rays. And following that, if the patient is doing well, every 6 weeks the patient is evaluated with the similar investigations. And at the end of 8 months, that is 2 months of intensive phase of therapy and 6 months of continuation phase of therapy, the patient is seen in the clinic again. But at this point, apart from these aforementioned investigations, we also obtain an MRI scan. And this MRI scan is important to take a decision whether the continuation phase treatment needs to extend for just 1 month more or 3 more months. So that we do, and we look for the signs of resolution as we had discussed in the previous slide on MRI. And if the patient is doing all well at the end of 8 months, then we stop the treatment at the end of 7 months. Otherwise, we continue the treatment for another 2 or 3 months. And if the patient's treatment was stopped at 9 months, we see the patient again at 12 months. We get the clinical evaluation, ESR, CRP, liver function, everything good. The patient can be discharged. So the surgical treatment, which obviously all of us are more important interested in. So it all started with Hodgson and Stark describing the Hong Kong procedure, which is an anterior approach to thoracothoracic thoracolumbar regions. And the initial MRC studies actually showed much faster resolution of abscesses, much better bony union, better alignment, and much smaller deformity in the patients who were treated with Hong Kong surgery as compared to the patients who were only on anti-tubercular treatment. Today, even in most centers who do more anterior surgeries, modified Hong Kong procedure is what we practice. Hong Kong procedure is a radical debridement where if there is an involvement of a vertebra, the vertebra is taken off as a whole. Whereas a modified Hong Kong procedure is debridement of only the diseased portion of the vertebrae and spinal fusion. By diseased portion, we mean we debride as long as we see good bleeding bone. So the sclerotic portion of the bone is all removed. This helps in better penetration of the drug into the bone or the infected tissues. This study, this was a landmark study by Yoga et al. And they had shown that the metallic implants are quite safe in spinal tuberculosis, and there is not much biofilm formation. And this actually changed our perspective towards surgical treatment. So overall, whenever we consider surgical treatment, we need to classify a patient, whether it's an uncomplicated disease or a complicated disease. As previously said, uncomplicated disease is all a medical disease. Whereas if it's a complicated disease, by which I mean if there is a neurodeficit, instability, there is a deformity or a disease unresponse, or a disease which is unresponsive to isolated medical treatment, then a combination of medical and surgical treatment should be considered. So Tully had described the middle path regimen. They had actually seen good outcome in their patients in their follow-up, even those with neurodeficit, and they were treated with anti-tubercular treatment and bed rest. So they put forth the middle path regimen whereby even patients with neurological deficit, they should be treated with chemotherapy initially, and only if there is a failure of response at 3 to 4 weeks at least of medical treatment, surgery should be considered. However, at this point, we don't entirely concur with this observation, as I previously have been mentioning. Drug-resistant tuberculosis is a big concern, and there are a definite group of patients whom we should identify even initially, because those patients are at high chance of developing deformities, progressive neurological deficits, even in the heal phase. So those patients do require a surgery, and we don't need to always follow this order like chemotherapy for 4 weeks and then only consider surgery. So the major goals of surgery in these patients: 1, spinal decompression; 2, abscess drainage or debridement of the diseased portion of the vertebrae; 3, maintenance or reinforcement of stability; 4, to prevent or correct deformity; and 5, to obtain a biopsy for tissue sample. I'll briefly go over the important surgical indications. There are absolute indications. With regard to decompression surgery, when a patient has severe neurodeficit, including bladder wall incontinence, that's an absolute indication for surgery. Or a patient with worsening or persistent neurological deficit despite some medical therapy, that's an absolute indication for surgery. With regard to stabilization, especially in the pediatric age group, any patient with a positive spine at rest spine, or a patient with a multi-level disease or a panvertebral disease, it's an absolute indication for surgery. A patient who has had a failed or inadequate tissue sampling from percutaneous biopsy, or in whom there is a doubtful diagnosis or not good response, that's an absolute indication for surgery. And whenever there is a large abscess or an unresolving abscess, or the symptoms don't resolve despite certain period of medical management, and when you're suspecting drug-resistant tuberculosis, it's an absolute indication for surgery. However, the relative or extended indications include whenever there is a chance, we think there is a chance that there can be progressive deformity, or a patient who can potentially have a neurological deficit based on the imaging findings can be considered for surgery. And in elderly patients, again, there is a low threshold in our institution to opt for surgery if they are fit, because it helps with early ambulation and a lot of other complications in these patients who are requiring long-term medical management. There are 5 principles of surgery in spinal tuberculosis. The first principle is obtaining tissue debridement. Second principle is a spinal canal decompression. The third, the principle of surgery is we need to see if there is a need for an anterior column reconstruction. And fourth, if there is a deformity, whether the deformity needs correction. And 5, stabilization or instrumentation. So based on the clinical scenario, the patient profile, at least some of these, if not all, principles need to be followed while planning the surgery in spinal tuberculosis. So with regard to tissue debridement, we went over this a little bit. You debride until there is bleeding cancellous bone. The main purpose of tissue debridement is to ensure good drug penetration into the infected tissues. We'll go over the rest in the coming slides. I wanted to discuss a few points on instrumentation. One of the questions that we all have in our minds is the levels of instrumentation. The ideal construct in tuberculosis, it should at least extend 2 levels proximal and distal to lesion. In the lumbar spine, if we are doing an interbody fusion, then it's okay sometimes to just do 1 level above and below the lesion. And it's always good to have pedicle screws at the infected level, and that significantly improves the strength of the construct. These 3 should be kept in mind in terms of principles. This was a chapter, and this is a good chapter which classified active tubercular infection into 2 types, and this helps us in guiding our approach, the aggressiveness of the debridement, and the levels of instrumentation of patients. So we classify the patients as a post-segment disease or a multi-segment disease first. So what we call as a post-segment disease, when the disease is limited to 2 adjoining vertebrae, is a post-segment disease. But when the disease extends beyond 2 vertebral bodies, either contiguous or non-contiguous, it comes under the multi-segment disease. These patients with multi-segment disease, they tend to have significant instability and deformity, and these patients usually have poor nutritional status and osteoporosis. So the surgical approach should be based on the age of the patient, the location of the disease, the associated comorbidities, the deformity magnitude, and last but not the least, the preference of the surgeon per se. So anterior approach, it's the anterior approach to the subaxial cervical spine is still the standard of care in tuberculosis. The advantage of any anterior approach is that it provides direct access to the pathology, and it provides a direct chance to do an anterior column reconstruction. As we said, in a Possi level disease, that is disease restricted to 2 vertebral levels without much kyphosis, so it is it's a suitable case for an anterior approach. Some people discuss the morbidity associated with the anterior approach, and it's obviously the surgeon preference, but in centers who do anterior surgeries, they to uh, uh, support this approach at all the levels, especially for POSI level disease. But whenever we do a multi-level, when there is a multi-level disease, just an anterior approach may not suffice, whether in the cervical spine or the rest of the spine. So a posterior instrumentation should definitely be considered. And also when there is a significant kyphosis, it should be a combined approach. It should not just be an anterior approach. This is all in active disease. The other approach is a combined approach. The literature says that when you do both an anterior and a posterior surgery, the chances of fusion are close to 100%. The typical candidate for a combined approach is when a patient has a multi-segment contiguous disease, especially at the junctional level. In patients with revision surgeries, again, this can be better approach. And again, when you do a survey, especially in the cervical spine, when you do operate in a patient with significant kyphosis, you need to reinforce it from the back. So a multi-segment disease is an ideal indication for a combined anterior posterior approach. At our institution, we tend to be more. It's actually things have evolved from an anterior only surgery to a posterior only surgery, and we do mostly stick to only posterior surgeries in tuberculosis. In POSI level disease with early involvement, with limited vertebral body destruction, just the posterior instrumentation with or without decompression actually gives good outcome. However, when there is a significant involvement or deficiency of the anterior column, you obviously need to if you go from the back, you need to do a global reconstruction. Can be done through an all posterior approach. So again, there we can decide our approach based on whether it's a POSI level disease or a multi-level disease. So in a POSI level disease with significant anterior deficiency, we can do a transfascicular or a transpedicular approach, and we can do a good anterior column reconstruction. Whereas if it's a multi-segment disease, we need to, with our approach itself, we need to be quite lateral. We need to take off the transverse process, part of the ribs at least, and then it's more of a costo-transversectomy kind of an approach. Minimally invasive surgeries have been very widely described. Thoracoscopic surgeries or endoscopic surgeries, minimally invasive till executions, lateral surgeries. So these have all been described for tuberculosis, and people are increasingly doing more minimally invasive procedures for tuberculosis. So there's a basic guideline, a flow chart. It's not, again, the decision is made on the surgeon's preference and based on the clinical scenario. But just to go over a basic guideline for treatment surgeries in active thoracic or thoracolumbar surgeries. In a POSI segment disease, we classify the patient as a POSI segment disease or a multi-segment disease. In a POSI segment disease, when there is not much kyphosis, then just either an anterior approach or a posterior approach surgery is good enough. Whereas in the kyphosis is significant, more than 30 degrees, then we need to, if you go from the back, we need to do both we need to do a global reconstruction either through the transpedicular or the transfascial approach. When there is a multi-segment disease, again, combined, it needs to be both an anterior and a posterior column reconstruction, and it can be done with a combined anterior plus posterior approach or a global posterior reconstruction through a costo-transversectomy approach. I am pretty sure centers do anterior surgeries even with significant kyphosis, but when there is a lot of kyphosis, it becomes very difficult to access the vertebral body from the anterior approach. So when there is significant kyphosis, either with a POSI segment disease or a multi-segment disease, it's usually easier to go from the back. Even doing an anterior column reconstruction is easier from the back. So there is always tuberculosis is not over with just the active disease. There is obviously a healed phase, and some patients, the problems with the healed phase are when the patient develops a severe post-tubercular kyphosis or neurological deficit. Most of the patients with healed tuberculosis, they end up with less than 15 degrees of kyphosis. However, 3 to 5% they go on to develop kyphosis more than 60 degrees, and these are the candidates whom we should, whom we may help sometimes. And buckling collapse is described as it's seen in patients who tend to have progressive kyphosis. When they develop a deformity more than 120 degrees, they develop the buckling collapse. And in such patients, they have severe back pain, and they start developing costopelvic impingement. And secondary to such a huge deformity, they have gastro-respiratory, cardiorespiratory issues, gastrointestinal issues, and they can develop a late onset neurological deficit. So the risk factors for developing severe deformities in our patients are young age, less than 7 years, junctional disease when there is a significant vertebral loss, and presence of spine at rest signs, especially in pediatric population. It's better prevented through our active intervention in the active phase of the disease rather than treated. So the approaches in late onset kyphosis, it can just be a laminectomy in a patient with a myelopathy or neurological deficit, who may not be very fit for big osteotomies and deformity correction surgeries. He may benefit from laminectomy or an internal gibectomy with stabilization. So that may be significantly helpful too. However, in patients who are candidates for deformity correction surgeries, various osteotomies can be used. However, in tuberculosis, it's a fused spine, right, anteriorly, or the spine is entirely fused. So the correction surgery needs to be a 3-column osteotomy in most occasions. So the osteotomies for deformity correction in severe kyphosis. So whenever the deformity is greater than 60 degrees, a posterior vertebral column resection can be helpful. The posterior vertebral column resection in tuberculosis is much more challenging than in congenital kyphosis, mainly because it's all fused spine and the anatomy is extremely distorted. Dr. Rajshekharan had described the closing opening wedge osteotomy in posterior vertebral column resection. Basically, the concept of this osteotomy is that there is a significant deficiency of the anterior vertebral column, and when we do a 3-column osteotomy with the PVCR, we tend to we shorten the posterior column definitely, but what happens is the anterior column also further goes on to further shortening. So that leads on to further buckling or kinking of the spinal cord that can cause more deficits. So by this approach, they actually describe cage insertion anteriorly, whereby the anterior column can be anterior column is opened along with a closing osteotomy of the posterior column. So that's pretty much the closing opening wedge osteotomy, the PVCR. And in severe deformities greater than 120 degrees, any of these osteotomies can be significantly complicated. So just an anterior stud graft with fusion and an internal gibectomy can be an approach that can be helpful. We also tend to use halo gravity traction over a period of time, but it's really fused spine over here, and it may not help in this in tubercular kyphosis. So brief idea regarding the principles of 3-column osteotomies in delayed tubercular kyphosis. In pauci-segment disease, when with kyphosis less than 70 degrees, a staged antero-posterior approach or a pedicle subtraction osteotomy can be helpful. When the kyphosis is more than 70 degrees, we may need a vertebral column resection or a POVO. In very severe kyphosis more than 120 degrees or buckling collapse, internal thrombectomy or anti-distant grafts is an option. If we uh, 3-column osteotomies are also options, but we should just have the complications in mind. Thank you. I request all of you to stay home, stay safe, stay healthy. Any questions?
Yeah, that was a very great presentation, sir. You covered from A to Z of all tuberculosis. So before proceeding ahead with the others questions, I have a couple of questions for you, sir. You have showed about the TB drugs. You used to continue for 7 to 9 months, right? Beyond that, you don't used to do. Is it a continuous, in sense, daily regime or an alternate day regime?
Mm. The alternate regime has been it should not be used. The WHO has advised against an alternate regime, so it should be a daily regime, definitely.
Okay. So the next question is, you told that you will be doing an MRI at end of 6 months, right? And based on the MRI features, you used to proceed for 7 or 9 months. Presume at the when
That's
you
the
do,
continuation phase.
yeah, in the continuation phase.
Yeah, so that will be 8 months. So the overall treatment would be for 9 or 11 months, including 2 months of intensive phase and 7 months of continuation phase.
Correct.
So at the last month, just before the last month, an MRI is done. And if the patient is doing well, then the drugs will be stopped after 1 month.
Okay. Presume at the end of the 1 month before your stop, you 8 month of the continuation phase, you feel that there is large abscess, still large abscess is there, but absolutely patient is asymptomatic. Would you prefer to continue the drug or you stop?
Yeah, the decision needs to be taken on a case-to-case basis. But if there is still a large abscess or something suggestive of a significant infection, then I would rather err in extending the therapy for another 2 or 3 months rather than stop it abruptly, and possibly get another MRI at the end of 12 months or 11 months, as long as I continue the medications. But definitely, if there is a large abscess at 7 months or 9 months, I would still think if there is something that's being missed, if the patient requires another the abscess to be drained or anything else that can be done. Yeah. I wouldn't stop with a large abscess.
Okay.
MRI at that.
So your MRI should say that it is completely healed without abscess. That's how you stop. So you depend on MRI for stopping the therapy.
Yeah, small abscesses many times we see, and overall the patient has been doing great. Clinically has improved, good weight gain, and X-ray has been showing good resolution of the bony lesions. Blood inflammatory parameters have all been coming down constantly. Small abscess, that may be fine. I may just see the patient a little bit longer. That's it, but I wouldn't continue. But if it's a large abscess, then yeah.
Thanks for that, sir. So any more questions?
Yeah, I have a question.
Yeah.
Hi, Vibhu. I mean, it was a very extensive presentation. Just one query, because right now you are in Ganga. I mean, in kids who have the spinate wrist sign, and you want to do something for them because you feel that you cannot manage them conservatively. So when you operate, like suppose there are D12 and L1 is involved. So like when you want to plan a surgery, like do you do a laminectomy and go anterior and then reconstruct, or like you just do the instrumentation and then just partially correct and allow the anterior granulation tissue to heal? I mean, what is an ideal surgery for these kind of children?
In kids,
Yeah,
if
kids,
there is a
kids.
significant
Yeah, kids with spinate wrist sign, you are planned for a surgery. So
is that if the patient is having a significant involvement in the anterior, I mean there were other slides which showed when an anterior column reconstruction is required. Right? If the kid has a, I mean it depends on the age of the kid, the size of the kid, everything. So if the kid is a little bit
young, like say 4 or 5 year old kid.
Yeah, You don't need to entirely take off all the diseased tissues in tuberculosis.
Okay.
But we just need to make sure that it's not a very large amount of sclerotic bone and all that, which may not help with a good medical therapy.
Yeah.
So in such a small kid, I think mostly just a posterior instrumentation and medical therapy would suffice.
Medical therapy. I mean, do you like prefer to give them a cast after instrumentation, or like you are okay with like leaving them? Because we are not very sure of our instrumentation hold. We are concerned that instrumentation can back out. So, any special precautions you take for these kids?
Some kind of raising can help, but I don't think a cast would universally be required. Yeah.
Okay. Nice presentation, man. It was like everything you need to know in TB.
Thanks.
Good.
So one more question that was coming up is, do you use P cage for anterior column support? Metal, yeah, it has been proven. P cage in anterior column support.
It has been used. I could see a few articles that mentioned P cages are good. We don't routinely use P cages at Ganga, but yeah, it can be used.
Should the abscess to be removed always during surgery? Yeah, that's one more question that usually comes up. See, we find some large amount of abscess, we try to take it off, but it's like we won't debride everything, right? And if you do start debriding everything, it will be like you're removing everything off, and you will be producing a deficient anterior column, right?
Yeah. You don't need to remove everything, as long as you feel that you have you have debrided a big amount of tissues. There have been two patients where I still remember that the patient, we didn't take off the entire disc. We just went posterior. The patient continued to have some or the other symptom. He didn't respond greatly. And then we went in anterior, and we took off the two infected discs and did an anterior fusion, and the patient significantly improved. So the main advantage of debridement is getting a better penetration of the drug into the avascular tissues, infected tissues. But yeah, you don't need to take everything off. It's primarily a medical disease, and we are just helping the bone to heal better.
Dr. Shivaraj?
Oh.
Yes, sir. Dr. Shivaraj, sir.
Yeah. Hello.
Yes, sir. Any questions, sir?
Yes, sir.
Any adds up? Hello? Okay, Nirdesh. Shivaraj, sir?
Yeah.
Yeah,
Hello.
you want to add up anything, sir?
Actually, I joined late. That's why.
Okay. Nirdesh. So one more thing. When do you decide to do an anterior column reconstruction?
Anterior column reconstruction, we do most from the posterior approach. So, as I said, taking off the disc, if there is a significant disease anteriorly, can actually help immensely with the fusion. So, if there is very little kyphosis, it's early disease, not much vertebral destruction, then just a posterior instrumentation may suffice. But if there is a significant involvement of the disc, then going transvascularly or transpedicularly, doing an anterior column reconstruction definitely helps better. I would have a low threshold if to do an anterior column reconstruction simultaneously if there is a significant disease.
Okay. So, any role of bracing in pediatric age group without deficits or deformity? It's one more question that comes up in chat. Role of bracing in pediatric age group.
role of aging, bracing in pediatric age group. If I personally think it's either a stable disease or an unstable spine, right? So if there is one of the spine interest signs, anything which we think it is unstable, then obviously surgery is a better option. We should always consider. Else, in adults we would we usually if we are planning non-operative management, then we take a call on whether the patient needs brace or not. If it is again we think it's very stable, then we don't. In kids, it may be very hard to put them on a brace for a long time. Then if we think it is stable, it doesn't require surgery, then maybe we can just watch.
So certain clinical scenarios do happen, right? So you do a biopsy, and despite of doing a biopsy, it comes inconclusive. Like it comes as chronic inflammation. You are either not confirmed of TB or pyogenic. So how do you manage those cases, sir? So you
Yeah.
give both drugs together, or
Yeah, I mean there are always the gray zones where it gets difficult whether to completely classify the patient as a pyogenic or tubercular. Um, Many things I think can be considered. If it is a thoracolumbar infection, non-diabetic, where I think less of a pyogenic spondylodiscitis, then I possibly would be more inclined towards diagnosis of tuberculosis. If it says chronic inflammation, chronic infection, and again it could be possibly tuberculosis. It can be, there can always be one little exception of a patient where we falter. Yeah, if there is a suspicion, then it's not clearly pyogenic, a call has to be taken. I possibly would if I have a real doubt, and I would think of anti-tubercular treatment. But again, it's not that anti-tubercular treatment per se is not completely harmless, innocuous. So needs to be balanced based on that patient. But there is always going to be that one odd patient where it's a dilemma. Maybe getting more colleagues involved, getting their opinion. I think that's more of a solution. Can't think of a black and white solution for that for some scenarios.
so biopsy is mandatory.
Biopsy is mandatory.
Yeah, Dr. Nirdesh.
Yes, sir. Sir, do you use P cages for anterior column support, or do you prefer mesh cages in tuberculosis, sir?
We at our institution we always use titanium cages for all patients. P cages can be used, but I don't think from personally from whatever I went over, that P cages are like contraindicated. They are used. So, but we use universally titanium cages.
Is there any reason for that preference, sir, of using mesh cage over P cage?
Nothing specific.
Okay, sir.
Nothing related to infection.
Because lately there are no literature as such over the P cage usage in TB. Even we tried to find out, but most of them they have used mesh cage. I could not get the reason. Is there any reason behind that? So just wanted to confirm that.
Yeah. I mean, I would go over if I can. I would, or maybe put down on the comments. Nothing that I
even in the lumbar, do you prefer this one, sir? Mesh.
We actually use rectangular cages.
Okay, sir.
Very even in the thoracic spine, a lot of times we have very big sized rectangular cages.
Okay, sir.
Bullet cages. Yeah, we tend to use them.
Okay, fine, sir. Thank you, sir. Thank you.
Hello.
Hello.
Guna, is there any question you want to ask up? Yeah, I think we are done for the day, sir. It's a good one, sir. Thanks for sharing your presentation with us.
Thanks.
Yeah.
Thanks.
Bye bye. Good night, sir. Good night.